Hello everyone, Assalamu alaikum. It is indeed my pleasure to give this keynote talk at the World Down Syndrome Congress, hosted by the Emirates Down Syndrome Association. I would like to extend my thanks to the organizing committee for inviting me, and I trust that this will be a successful Congress. Before we start, a little bit about myself. My name is Ammar Albanna, and I'm a child and adolescent psychiatrist by background. And I overlook a mental health center of excellence at Al Jalila Children's Hospital in Dubai, where we host a comprehensive autism program, and this is a photo of our autism team, in addition to conducting research on autism in the United Arab Emirates. The topic I'll cover today is the overlap between autism spectrum disorder and Down syndrome. This is an outline of my presentation. I will start by talking about a brief overview of Down syndrome, and then about autism spectrum disorder, and then about the diagnostic overlap between the two disorders, as well as clinical and treatment implications. So now let's start by talking briefly about Down syndrome. Since this is the topic of the conference, this introduction is going to be very brief and to the point of the presentation. As you all know, Down syndrome is a genetic disorder that is due to different genetic causes, but most commonly trisomy of chromosome 21, where the affected child ends up having 3 copies of chromosome 21 instead of the usual 2 copies. It is also important to note that Down syndrome is the leading genetic cause of intellectual disability, with most individuals falling in the moderate range and some of them even in the severe range of intellectual disability. The prevalence increases with maternal age, as it is well established. Down syndrome is named after Langdon Hayden Down, who first diagnosed this syndrome in 1862. Individuals with Down syndrome tend to overall have relative weaknesses in verbal skills compared to nonverbal abilities, but stronger receptive language than expressive language, as well as difficulties in attention and externalizing behaviors. In general, children with Down syndrome present with common personality features, such as being cheerful and friendly, and in some studies, they were shown to have relatively lower levels of parenting stress compared to children with other disabilities such as idiopathic intellectual disability. However, children with Down syndrome may get an additional diagnosis, and this is the topic of today, including autism spectrum disorder. And this may very well further complicate the clinical presentation, as well as pose further challenges to parents and families. We will now shift gears to talk about autism spectrum disorder. Autism spectrum disorder is, number 1, a heterogeneous disorder, and number 2, a complex disorder. It's a complex and heterogeneous neurodevelopmental disorder, and by neurodevelopmental we mean that it impacts the brain development during the early stage of development, and by heterogeneous we mean that every child is different than the other child in terms of the underlying etiology, in terms of the clinical presentation, in terms of the symptoms. And the saying is that if you have met one child with autism, you have only met one child with autism. In other words, the other children you're going to meet are going to be very different. The main characteristic in autism spectrum disorder is impairment in reciprocal, social, and emotional communication. And these are, in the slide, the DSM-5 symptoms of autism spectrum disorder. The child with autism must present with core deficits, so deficits in social emotional reciprocity, deficits in nonverbal communication, difficulty maintaining and understanding relationships. So notice that all these core difficulties are in the social communication domain, and they must be present in every child in order to be diagnosed with autism spectrum disorder. In addition to this, we need 2 or more of the following symptoms including stereotypic repetitive movements, ritualized behaviors, restricted and fixated interests, as well as sensory symptoms. We see here that from the earlier descriptions of autism by Leo Kanner in 1943, he described that children with autism come into the world with the innate inability to form usual biologically provided affective contact with people, just as others come into the world with physical or intellectual handicaps. And by this, he is differentiating the social and emotional difficulties that characterize autism from other disorders such as intellectual disability. Autism is more common in boys, as we all know, and there is overall an increasing prevalence in autism spectrum disorders worldwide. Although the causes of the increased prevalence include primarily things like increased awareness, increased recognition, increased screening, availability of treatments. These are the main causes behind the increased prevalence. Although we know that autism is genetic in its origin, meaning that genes play an important role that can exceed 90% in explaining why some children have autism. But the underlying genetic risk factors are more complex compared to Down syndrome, and we are in the process of understanding the different genetic causes of autism and their roles. Therefore, we introduce autism as heterogeneous, meaning that you can have a child with autism that is due to a specific genetic disorder and can present differently compared to a different child who presents with autism in the context of a different genetic disorder, such as Fragile X or tuberous sclerosis, Rett syndrome, and other conditions. The etiology of autism is quite complex, and it is beyond the scope of this presentation today. Although this is very well established by now, but I think that it's still important to remind ourselves and everyone that autism is not caused by vaccines. Vaccines do not cause autism, very clearly. This is based on high quality evidence and studies and meta-analysis. This slide from Autism Speaks is quite important and informative. It shows that children with autism, if you see the two blue bubbles in the middle, represent the core symptoms of autism. Children with autism present, in addition to the core symptoms, they can present with variable degrees of comorbid presentations, including strengths, by the way, or difficulties. This may include language disability, and this, by the way, may include also children who have strong language abilities and are on the autism spectrum. Or other difficulties such as irritability, tantrums, self-injurious behaviors, ADHD, sleep difficulties, mood and anxiety disorders, as well as medical conditions such as seizure disorders, for example. And some children with autism present with intellectual disability versus others who present without intellectual disability. And in fact, there is a subset of children with autism who may present with very strong cognitive abilities in specific domains. These comorbid conditions can further complicate the clinical presentation, the functioning of the child, and warrant evidence-based targeted interventions. We will now talk about how we diagnose autism spectrum disorder and evaluate autism spectrum disorder in a child. So autism is usually evaluated through a multidisciplinary team, utilizing both structured and unstructured components, as well as evidence-based ways to assert whether the child meets the diagnostic criteria for autism spectrum disorder. These diagnostic tools may include ADOS-2, the Autism Diagnostic Observation Schedules, or specific tools to measure cognitive abilities, or other evidence-based tools. Although we do not rely on one single tool to diagnose autism, it is made through a multidisciplinary team evaluation utilizing these tools, as well as other methods to diagnose the child. And following a structured evaluation, the goal is, as we mentioned, one, to assert whether the child meets the diagnostic criteria or not, but also the goal is to identify any unique strengths that the child might have or present with, or even levels of impairments and difficulties that warrant specific plans to be put in place. When it comes to the treatment of autism, it is important to highlight that currently there is no medication approved for core symptoms of autism. If you remember the two blue bubbles in the middle, there is no medication for core symptoms of autism, neither any biological intervention for the treatment of core symptoms of autism at the moment. There are ongoing studies that target core symptoms of autism, but we are awaiting the results from these studies. But this does not mean that we don't have any treatments for autism. In fact, we do have effective treatments for autism, including evidence-based behavioral strategies. The most effective strategy that has been studied in autism, and the slides present some of the strong evidence behind the effectiveness of early intensive behavioral intervention, especially when applying principles of applied behavioral analysis, or ABA, from an early age in an intensive manner from at least 25 to 40 hours a week. This has been shown to result in gains in IQ, adaptive functioning, especially when implemented early on and intensively with high quality, as we discussed. When it comes to comorbid conditions, there are effective treatments for the treatment of comorbid conditions of autism, such as, for example, treating ADHD with stimulants or non-stimulant treatments, and as well as sleep difficulties with melatonin, for example, irritability with antipsychotics, and targeting seizures as a comorbidity. And I would like to encourage the audience to refer to the recently published local Dubai Autism Guidelines for further information, posted on the Dubai Health Authority website. This includes details on the evidence-based evaluation as well as early intervention for autism, especially in the context of widespread misinformation on treatments of autism. After this tour about autism and Down syndrome, we will now talk about the third and final aspect of the presentation today, which is regarding the dual diagnosis and the overlap between autism and Down syndrome. So the first question that occurs to everyone's mind is, how frequent is autism among individuals with Down syndrome? So it is important to start by saying that it was previously thought that autism was extremely rare among individuals with with Down syndrome. Even prestigious authors described that, as we see in this quotation, that evidence did not suggest that the comorbidity is higher than expected by chance. But we now know that this is not the case, as recent estimates of autism among children with autism showed that the prevalence ranges between around 16 to even 40%, with males being at higher risk of autism compared to females. This is in line with the general epidemiology of autism. Before going into details about prevalence studies, we should highlight and emphasize that, unfortunately, ASD is typically diagnosed at a later age in children with Down syndrome compared to ASD or autism among children who don't have autism. Who don't have Down syndrome. So, and this is really important because identifying autism early on opens the gates and doors towards treatment interventions. So in some studies, the average age of diagnosis of autism and Down syndrome was even above the age of 10. But this is also a recent meta-analysis and systematic review of the prevalence of autism spectrum disorder among different genetic disorders. And in this study, the prevalence among Down syndrome was found to be approximately 16%, as we can see in this slide. So the next point is, what are the characteristics of children who have both Down syndrome and autism spectrum disorder? So studies have shown that children with both conditions are more likely to have history of developmental regression, specifically in the language and social skills domains, repetitive motor behaviors, unusual vocalizations, unusual sensory responsiveness, feeding problems, increased anxiety, irritability, and difficulties with transitioning, hyperactivity, attention problems, and significant sleep disturbances. And in the next slide, we see that on autism-related scales or behavioral scales, such as the Aberrant Behavioral Checklist, which is an empirically developed scale designed for measuring psychiatric symptoms and behavioral disturbances in children with intellectual difficulties. Children who have both conditions, Down syndrome and autism spectrum disorder, were shown to have higher levels of preoccupation with body movements and object use, and less impairment in social relatedness, and they scored higher on all 5 subscales of the Aberrant Behavioral Checklist compared to children with severe cognitive impairments alone. Next, what are the cognitive behavioral characteristics of children who have both Down syndrome and autism spectrum disorder? In this study, recently published by Bradbury and colleagues, 3 groups of children were compared. 23 kids who had both autism spectrum disorder and Down syndrome, 99 with autism and intellectual disability, and 38 kids with intellectual disability alone. The results revealed that children with both Down syndrome and autism spectrum disorder had the lowest adaptive functioning skills among the 3 groups. However, it is also important to note something quite interesting from this study. So this study showed that individuals with co-occurring autism and Down syndrome showed fewer emotional and behavioral concerns compared to intellectual disability group, despite that they had lower cognitive skills and overall lower adaptive functioning skills. Their behavioral functioning and ASD symptom severity were similar to those with autism and intellectual disability, except that those with ASD and Down syndrome had lower levels of disruptive behaviors. So next, and we can see the results in this slide. So next, what are the barriers to the diagnosis? What could be barriers to diagnosing autism in children with Down syndrome? So these are some of the barriers. One, lack of awareness. As discussed earlier, ASD was perceived to be extremely rare. So next, we're going to talk about the advantages of diagnosing ASD in children with Down syndrome. But before this, what are the barriers to diagnosis? So barriers include lack of awareness. As we discussed earlier, ASD is perceived to be rare among children with Down syndrome, although this is not the case based on the evidence that we showed. So we need to really raise awareness about the prevalence of autism among individuals with Down syndrome. And second, Down syndrome may be easier to diagnose. The facial features and body features can be identified early on and really confirmed through genetic testing, karyotyping. Whereas autism spectrum disorder requires more comprehensive assessment with a lot of subjectivity. The assessment of autism may not be available in all locations, and sometimes it's available but not easily accessible. There's also the phenomenon of diagnostic overshadowing. So sometimes when clinicians see a certain disorder, they attribute the difficulties to the primary diagnosis. In other words, if a child has Down syndrome, they might attribute autism-related comorbid symptoms to Down syndrome itself, which is what we call diagnostic overshadowing, and this could be a barrier. And also the overlap of symptomatology. There is some overlap between some of the Down syndrome core symptoms as well as autism spectrum disorder symptoms. So what are the advantages of diagnosing autism in Down syndrome? First, to help better understand the child. So to set the developmental expectations and to identify the child's strengths and challenges in order to put the appropriate support systems in place for this child. And also, some families get a sense of relief and clarification and explanation for why their child was struggling with these difficulties. They may have questioned, why does my child with Down syndrome struggle with friendships and doesn't have friends and have difficulties with eye contact, is not similar to other kids with Down syndrome. So this diagnosis, comorbid diagnosis, can provide answers to parents. But I just mentioned that it can be relieving to some families. On the other hand, the response can be a little bit more difficult for some families who can find it as a second shock following the shock of their child being diagnosed with Down syndrome. So it is important for clinicians to be attuned with the emotional responses of families, and sometimes we can have different responses among the same family, which is important to pay attention to. And importantly, one of the most important advantages of diagnosis is that once you have a clear diagnosis, we can follow evidence-based interventions for that condition. So this will open the doors for evidence-based interventions, including applied behavioral analysis, ABA, targeting social communication deficits, as well as connecting families with other families who have kids with Down syndrome and autism spectrum disorder, or sometimes even just with autism spectrum disorder community. This can help the families feel more connected and more resourceful in terms of identifying available resources and support. And it's important to talk about one point: wait lists for autism. As we mentioned, accessibility can be one of the barriers. But it is important to really start the intervention early on. So even after a clinician suspects autism, once the child is on a wait list for a diagnostic assessment, we usually recommend that the child starts the treatment, the intervention, and then following the assessment, the intervention can be tweaked or improved or enhanced or tailored for the child following the assessment. And finally, and it is also important to remind ourselves that what is the goal of the assessment? It's not just to put a label of the child on the child. It's not just to put a diagnosis in place. It is actually to try and understand this child, understand the unique strengths that this child presents with, as well as the difficulties, in order to put a personalized, tailored plan in place. Finally, always remember that the diagnostic label, whether it's autism or anything else, does not change who your child is, but it may influence the level of support your child gets and put your child on more treatment, open the doors for more treatment options for your child. So what happens after the evaluation? You may access reliable information about autism, connect with networks, as earlier discussed, and the child would be provided with appropriate evidence-based interventions, as well as the possibility of targeting comorbid conditions that we typically see with autism spectrum disorder. I don't think we have time right now to go over all the conditions, but we'll be happy to answer questions during the Q&A section. And in this slide, we see a case study from Algeria's children showing the effectiveness of behavioral interventions in an adolescent with Down syndrome and comorbid depression. So I just showed this to highlight that autism is not just the only comorbidity. There are other mental health concerns and issues that may rise up and require interventions, and there are effective interventions in place that are available. And I also wanted to highlight that at Algeria Children's we have an educational program for children, for parents of children with autism spectrum disorder, named Blue Cafe, where we provide information, training, and networking opportunities. And we also partnered with Autism Speaks to create a set of educational documents for Arabic-speaking parents, and more recently with the Emirates Autism Association, including the first 100 days document. For more information, feel free to visit the website of Algeria Children's. In conclusion, Autism is prevalent among children with Down syndrome. Children with both conditions may present with unique strengths as well as challenges, and obtaining a diagnosis can open the doors for networking, support, and for evidence-based interventions for the child. Finally, thank you very much for your attention, and I would like to again thank the organizing committee for this opportunity, and I look forward to taking your questions.